Welcome to this educational video on endovascular treatment of cerebral vasospasm. The objectives of this session are firstly to define cerebral vasospasm, secondly to understand how cerebral vasospasm is diagnosed radiologically, and lastly we're going to review some endovascular treatment strategies for symptomatic vasospasm. Cerebral vasospasm refers to the reversible narrowing of the cerebral arteries that is most commonly seen following aneurysmal subarachnoid hemorrhage. Vasospasm reduces blood flow to the region of the brain supplied by the artery, which in turn may lead to an ischemic event. Vasospasm typically occurs between 3 and 10 days following subarachnoid hemorrhage. There is radiographic evidence of vasospasm in approximately 70% of patients with subarachnoid hemorrhage. However, radiographic vasospasm does not always correlate with clinical symptomatic vasospasm. Symptomatic vasospasm is diagnosed when there is radiographic evidence of vasospasm and the patient experiences neurologic symptoms. Accordingly, only 1/3 of patients develop symptomatic cerebral vasospasm following subarachnoid hemorrhage. Early recognition and treatment of symptomatic vasospasm is important because it accounts for approximately 20% of disability and deaths related to subarachnoid hemorrhage. There are 3 primary imaging modalities that can be used to identify vasospasm, namely transcranial Doppler ultrasound, CT angiography, and conventional cerebral angiography, which is considered as the gold standard. Transcranial Doppler ultrasound is a non-invasive imaging modality that can be used as the first imaging tool in order to monitor and screen for the presence of vasospasm. This imaging technique provides an indirect measurement of vessel caliber by way of blood flow velocity. In particular, it detects elevation in mean blood flow velocities involving the middle cerebral and internal carotid arteries with a reported sensitivity of 99% and a specificity of 67%. CT angiography is a relatively non-invasive imaging modality that is typically used to identify a cause for subarachnoid hemorrhage and to further investigate patients who are experiencing worsening neurologic symptoms. CT angiography has been shown to be very accurate in the diagnosis of vasospasm with a reported sensitivity of 95% and a specificity of 99%. On the left side, we have an image of a CT study that demonstrates severe narrowing of the proximal left middle cerebral artery in keeping with severe vasospasm. Following endovascular treatment, a repeat CT study showed that the caliber of the affected vessel had returned to normal, as demonstrated on the image on the right. Endovascular treatment of symptomatic vasospasm includes both pharmacologic and mechanical interventions. Endovascular pharmacologic treatment involves the use of catheters, which are depicted on the right, in order to perform intraarterial injection of vasodilators, which serve to dilate the affected cerebral artery. This technique can be used in conjunction with mechanical vasodilatation, which is also referred to as balloon angioplasty. Pharmacologic treatment has been shown to have a clinical response in about 20 to 50% of patients with symptomatic vasospasm. In comparison, balloon angioplasty involves the use of a balloon catheter, depicted on the right, in order to mechanically restore the vessel to its normal caliber. Balloon angioplasty is used for moderate to severe vasospasm involving the large caliber arteries, including the internal carotid artery, M1 segment of the middle cerebral artery, as well as the basilar artery. The following animation will demonstrate the process of endovascular balloon angioplasty of a cerebral artery under vasospasm. As we discussed previously, vasospasm results in the reversible narrowing of the cerebral artery. If the patient has been diagnosed with symptomatic vasospasm, then endovascular treatment with either pharmacologic or balloon angioplasty could be considered. The patient would subsequently be brought to the interventional radiology suite. Under general anesthetic, vascular access would be obtained typically using a femoral approach. A wire would then be carefully advanced under fluoroscopic guidance until it reached the target artery. After this, a balloon catheter would be advanced over a wire, and the balloon would be slowly inflated in order to restore the native vessel caliber. Endovascular pharmacologic treatment of vasospasm would occur in a similar fashion, except instead of using a balloon, a vasodilator would be injected directly into the catheter. Endovascular treatment is generally reserved for patients who have failed medical treatment and are exhibiting neurologic symptoms such as a decreased level of consciousness and or focal neurologic deficits. Although very rare, the main complications associated with endovascular treatment are vessel rupture or dissection, as well as arterial occlusion causing a stroke. With that information, we will now review a real case of a patient who was treated for symptomatic vasospasm. The patient is a 45-year-old female who presented to the emergency department with confusion. Her past medical history is significant for untreated hypertension. A CT head without contrast performed shortly following presentation showed diffuse subarachnoid hemorrhage with filling of the perimesencephalic cisterns. Following this, a CT angiogram, which is shown on the left, was performed. It revealed the presence of an aneurysm arising from the left anterior communicating artery. Therefore, the cause of the subarachnoid hemorrhage was deemed to be aneurysmal. In order to further confirm this, a conventional cerebral angiogram was performed, and it confirmed the CT findings. This is shown in the middle image. The image on the right is a 3D reconstruction of the aneurysm that was used to plan the coiling of the aneurysm. The aneurysm was successfully coiled, however, serial ultrasound studies raised concern for vasospasm involving the left internal carotid artery and left middle cerebral artery. Clinically, the patient was experiencing a decreased level of consciousness, and a repeat CT study was performed 6 days following their initial presentation to hospital. In the image on the left, the red arrow is pointing to the coiled aneurysm. The image in the top right shows moderate vasospasm in the left distal internal carotid artery relative to the contralateral side, which is depicted in the bottom right image. The patient was subsequently diagnosed with symptomatic vasospasm, and a decision was made to treat this patient with endovascular balloon angioplasty. Here is a selected portion of the pre-angioplasty cerebral angiogram, which demonstrates moderate vasospasm in the left distal internal carotid artery. The circle indicates the coiled aneurysm, and the blue arrow indicates narrowing of the distal left internal carotid artery. A balloon catheter was subsequently positioned in the distal left internal carotid artery. The blue arrow indicates that the balloon was inflated in order to restore the normal caliber of the vessel. A post-angioplasty cerebral angiogram showed significant improvement in the caliber of the affected vessel, as indicated by the blue arrow. In summary, vasospasm refers to the delayed, reversible narrowing of the cerebral arteries that typically occurs following aneurysmal subarachnoid hemorrhage. The radiologic diagnosis of vasospasm includes ultrasound, CT, and conventional cerebral angiography. Endovascular treatment options for symptomatic vasospasm include both intraarterial vasodilator therapy and balloon angioplasty.